Okay, so we'll start the symposium on molecular allergology. It's my pleasure to welcome Dr. Patrick de Lobel, who is working with at Thermo Fisher for 35 years now. He had worked with molecular allergology for many years, and he's from Belgium. Welcome, Dr. de Lobel.
Thank you very much. It's really a great pleasure to be invited here in Lebanon. It's a splendid city. Beirut, I was here 15 years ago. It changed completely. And I think it's nice to see that so many people are interested in molecular allergology. We have been working with molecular allergology for over 15 years, and I think we start to see now where it all boils down to and where we go with this. First of all, as you know, as a physician, the key part is always to start with the patient and to take a good clinical history. Because the better you do this, the better your first step is, the more relevant information you will get out of the products that you have. Then we go for, once we have the symptoms, we're going to look at which are the allergens that can cause the disease. We're going to precisely try to define which are the allergens, and once we have decided which allergens it is, then one can look at the components. One can look at the specific molecules in the different allergens. They will tell us a lot about the cross-reactivity between the different species, and you have cross-reactivity everywhere. You have it with bee and wasps, you have it in the plant domain, you have it in the animal domain, so you find them everywhere. And then we can look at cross-reactivity in allergens, which will explain why people are allergic to different substances which are related proteins, or if it is a co-sensitization, in which case there is no relationship. Patient is allergic to primary sensitizers of the different allergens. So what are we going to try to do with components? We're going to try to do three things. I'm going to try to explain to you what it means from a diagnostic point of view, that we have a better diagnostic tool, an improved diagnostic tool, that we have a better prognosis for the patients, so that we can see what the outcome is, especially in food allergy, and that we can have a better management of the patient. How do we deal with the management? Is the patient potential candidate, for example, for desensitization, or is he not a potential candidate? You know it's an allergy, and you have a positive result to an allergen, but do you know as a clinician how severe this allergen is? Do you know whether this patient which is allergic to peanut is having an oral allergy syndrome to peanut, or as the risk for anaphylaxis or a systemic reaction to peanut? That's something that can be solved by molecular allergology. Have we identified the true cause of sensitization? We might have a positive result, but is that positive result really indicating what has been the primary sensitizer, what has really been started the sensitization of the patient? It's also something that molecular allergology can help you solve. And is your patient optimally managed? When do I have to see my patient again? Is this patient, can we change something? Is the eviction, do we have to avoid all type of foods, or can we introduce it in a certain way? And I think it all boils down to allergen components which are involved. And when we look at the source of an allergen, and you have one allergen source like an apple or a peach, then we know that in this source it contains thousands of molecules. Out of these thousands of molecules that you have there, very few are allergic. I think in most of the cases when we go to plants and other things, there are probably not more than 10, sometimes only 2 or 3 or 5 proteins which are really causing the allergen. The other ones give no reaction at all. So that is why we see that a lot of the allergen, a lot of the proteins are not relevant for allergic reactions. So then when we have a sauce, you see here birch and peanut and apple, we make an allergen extract. When we make an allergen extract, all of you know that when you extract things, you also will lose a certain amount of proteins. One of the things we can also do in molecular allergology, and we do in our products, is to spike certain of our extracts when we couple them to make sure that proteins which would be not optimally represented in the extract still are on our ImmunoCAPs so that we can have the correct clinical result. Those extracts contain specific components which are specific for the species. For example, in cat, the FeLD1 is a protein which is only found in cat. Or it can contain cross-reactive allergen components. That means components that are so similar in structure that the IgE reacts to similar structures. When we look at components, we're going to look at 5 things which are important to components. The first thing is this component specific for what we are looking for? The second, is it a cross-reactive component? If it's a cross-reactive component, do we have to take into account other possible sensitizations of the patient? The stability of the component is of key importance because the stability of the component will give in foods the possibility of either having an oral allergy syndrome or having a systemic reaction. And the amount of the protein that is available of this component in this specific product. So if you look for mites, for example, and you look at their P10, which is the tropomyosin of mites, you will see that the concentration is very small. So the result is that it's not a big contributor, where for their P1, their P2, the concentration is present in high amounts, so they are big sensitizers. And we will also look at the relative level of IgE antibodies to the different components. That also gives us a good picture of what could be the primary sensitizer for the allergens. So let's look at specific components in different areas. You have a few examples here for primary sensitization of specific components. You have the APM1 for B. You have the GALD1 for egg or ovomucoid. You have the FLIP-P1 and FLIP-P5 for Timothy grass. You have the birch, the BED-V1, which is a PA10 protein. And you have the ARA-H2, which is a storage protein, which is important in peanut. Those are examples of specific proteins for those. Now, why do we have cross-reactivity or cross-sensitization? We have cross-reactivity and cross-sensitization because the molecules look so similar. Here you have 2 pictures of PA10 molecules. They look so similar in structure that the IgE doesn't make the difference. It's the same by the plants. If you look at profilins, the profilins which are present through the whole plant kingdom, they have so similar structures that if you're allergic to one profilin, you're likely to react to another one. This is maybe a bit a complicated picture, but it's just showing you the amino acid sequence of PA10 proteins in birch. And then you see that this is very similar to the one in hazel. It's very similar to the one in apple, in cherry, in apricot, in pear. But if you would look at, for example, carrot, at DALC1, which is the PA10 protein from carrot, that's already quite far away. So the closer the species are related, those are all Rosacea, the closer the species are related, the more chance there is that the proteins have similar structures, and the more chance you have that you have cross-reactive. You know as a clinician that, for example, you have a lot of cross-reactivity with stone fruits, and this is this cross-reactivity due to the Rosacea family and due to PA10 proteins. Now, when we look at allergy, we also have to know that there is always a regional component in allergy. Allergy is not the same, like the economy is not the same in Germany and in Spain. Allergy is not the same in Germany and in Spain. These are all patients with cherry allergic patients. They all have cherry allergy. Now, when we look at the group in Germany and Switzerland, 68% have only oral allergic syndromes. If we look at Spain, it's 50%. But when we look at the systemic reactions, you see that 50% of the Spanish have systemic reactions, and I would expect very similar results in Lebanon. And when you look at the systemic reactions in Germany, it's only 1.7%. So for a German allergologist, cherry is not a very severe allergy. For a Spanish allergologist, it is a very severe allergy. And I think the explanation lies in the proteins. You can see that what has really happened is that the PRU-AV1, which is a PA10 protein, and is basically Birch is a primary sensitizer for this protein, and it's a heat-labeled protein. So the result is it's broken down in the mouth, and it doesn't give any reactions outside oral allergy syndrome. And if the Birch has been stimulating it, you don't have Birch in Spain, so you don't have this PRU-AV1 protein present. While the PRU-AV3 is a lipotransfer protein, it's a stable protein. You also find it in parataria, and that's why I think you have a lot of parataria here. You most likely would have a similar type of situation as Spain. That it's stable, and it means that a patient will have the chance of systemic reactions because it's stable. You find very few patients in the Germany and Switzerland with this lipotransfer protein positive. So it's really the molecules which explain why you have the difference between this Spanish group of people and this German and Swiss group of people. And you can see this in hazelnut, it is exactly the same. You see that in North Europe you have the COR-A1, which is again a protein which is very similar. It's a PR10 protein, very similar to the Birch protein, and you see it's represented substantially in the north, and it's not represented in South Europe. While when you look at the COR-A8, which is a lipotransfer protein, you see that it's represented in a much bigger way in Southern Europe. So we see that local oral allergy syndromes are much more frequent in Northern Europe, much less frequent in Southern Europe, and that systemic reactions due to lipotransfer proteins, they are uncommon in Northern Europe, but they are very frequent in Southern Europe. And I think the proteins have given us the explanation why, when we talk to a clinician in Sicily, he said, when I have an apple allergic patient, if I cook the apple, he still cannot eat it. And when you go to whatever allergologist in Sweden or Germany, he say, when you cook the apple, the patient can eat it, because it's the same type of issue that you have with this BED-V1 cross-reactivity with MALD-1 in apple, as you see here in this one. So, sensitization to specific components guide avoidance recommendation, I think. It also showed that it has an influence on selecting the patients for immunotherapy because it will influence the outcome, and suggests cross-reactivity also can suggest further investigation to find primary sensitizers. So when you have a cross-reactivity, you could also say, is this really the primary sensitizer, or do I have to look somewhere else? I gave you this for immunotherapy. We will not concentrate on the birch pollen because you don't have it, but we will concentrate on the Timothy grass. When you have Timothy grass, you have patients which are positive to Timothy grass, and pollen allergy is confirmed. Then one can go for component resolved diagnostics. If these patients are allergic to FLIP-P1 or FLIP-P5, which are two specific components for grass allergen, you will see that the outcome of your immunotherapy is very good. especially if they are also negative to the profilins like FLIP-P7 or FLIP-P12. If they are positive to all of them, as one FLIP-P1 as FLIP-P5 and FLIP-P7 and FLIP-P12, you will have a medium result of your immunotherapy. And if they are not allergic to the main components, the results of your immunotherapy will be not good. And it has been done. This is a study from Peter Schmidt in Switzerland, where you see he had about 700 patients with birch and grass pollinosis that he treated with SIT. And those patients, here you see the improvement rate, those patients which only were allergic to the major components give very, very good result. Here we have the number of patients in each group. And when you look at the ones which were positive to both, you see that the results are still worthwhile doing, but a bit less good. And when you look at the patients which were not allergic to the major protein, you could see that those patients will not give a good result with immunotherapy. And still we have to see that in this case, it's 15% of the patients which got immunotherapy, because it was a retrospective study, 15% of the patients which retrospectively should not have had immunotherapy. And I think it's quite important to make this type of selection, because immunotherapy is a fairly long process. And a similar study has been done by Plebani in Italy, and there he came to the conclusion that 40% of the patients in this group of patients he selected were not suitable for immunotherapy. You have the same with mites. If you are allergic to their P1 and their P2, it has been published by Pittner. If you are allergic to their P1, their P2 alone, you will have good results with immunotherapy. If you are in additional allergic to DERP10, which is a tropomyosin, you will have medium results. But if you are only allergic to DERP10, you have the chance of having low response. And it's also the question that when people make every extract company try to make the best possible extracts, but they're all standardized on the main components, which mean their P1 and their P2. Valenta has proven that the concentration of their P10 in allergen extracts used for immunotherapy can vary 100-fold from batch to batch. So you could not expect to have really good results on their P10 positive patients. But the P10 positive patients will be also those patients who shows this cross-reactivity of tropomyosin. So you will find those patients which are allergic to mites and at the same time might react to other invertebrates like snails or like shrimps. Another case is the double positive venom tests. I mean, it has been a big problem in Europe. I think that when people are doing testing for Hymenoptera, you get results which are positive for bee and wasp. And the question is, do I have to treat the patient with a bee extract, with a wasp extract, or with a combination of both? And we know that bee and wasp venom is containing very high amounts of carbohydrates. Carbohydrates, which are most of them in bee and wasp, single glycan-ended carbohydrates, cannot cross-link and cannot liberate histamine. So when we have this, we can look at it and look at it. You have here, you can have a high level for honeybee and one for yellow jacket at 5 kilo-units. And the question is, what do I do? Do I treat the patient with both venoms, desensitization, or do I choose for one? And here, I think you can see that the results will give you, the results of the components will give you the solution. If you have patients which are allergic to RAPM1, that's the phospholipase 2 of the bee venom, then you know that this patient is genuinely reacting to bee. If he's reacting to the protein 5, also known as RSV5, which is specific for the wasp and the polystes, you will see that he is reacting to that as well. So if you have a patient only positive for RPM1, you should only treat him with honeybee desensitization. If you have a patient which is allergic to both RPM1 and RSV5, you have to treat him with both. If he's only positive to RSV5, you only have to treat him with WASP. And I think it's quite common to find double sensitized patients as well in skin prick testing as in ImmunoCAP testing for B and WASP allergic patients. The protein stability. In the proteins we have proteins which are stable and we have proteins which are labeled. We have already taken this before, and the stability goes that the profilins are very unstable, the PR10 proteins are not very stable either, the lipotransfer proteins are stable, and the storage proteins are very stable. When it comes to inhalant allergens, it's not really important. The PR10 proteins, they are not stable, but as they come into the nose and into the lung, they will anyhow create reactions. It's only in the food allergic patients that the PR10 proteins are destroyed at the level of the mouth and only give the other allergy syndrome. And so the increase of the severeness of the reaction will depend on the type of proteins involved. And the more stable the protein, the more risk for systemic reaction. And that's just, as explained, you have labeled proteins, they give local reactions. And when you have stable proteins, they give systemic reactions, even sometimes late reactions. So with GLIAM5 and GLIAM6, where you have these problems after exercising and eating pasta, because these could only be resolved into the gut because they are very stable. Another thing that we touched upon was the level of specific IgE. I think it's important to have a quantification of specific IgE. This case is cat, where you see a very high level of FeLD1. FeLD1 is a specific protein for cat. And then you see a relatively high level of FeLD2, which is a serum albumin of cat. And you see a very low level of CanF3, which is a serum albumin of dog. So if you would do the test on this patient, you would see that cat and dog is positive. But if you look at this picture, you know that the primary sensitizer is the cat, because you have this high level of FeLD1, you have a fairly high level of FeLD2, cat albumin, but you have a low level of the dog albumin. So the cross-reactivity here is from the dog, who just has positive result by cross-reacting on the albumin with the cat. So we can assess the clinical risks, we can explain the symptoms of cross-reactivity, we can identify patients for specific immunotherapy. Go through a few of recommended profiles that you could have. We have a lot of those, but I will not do all of them. I'll just give a few examples. You have this patient, you have tested him on egg white or egg yolk. If he's allergic to egg yolk, you should believe that there is a chance of what we call an egg bird syndrome, where he will also be reacting to chicken meat. If he's allergic to egg white, it's important to know whether he's allergic to ovomucoid. This is a stable protein, so it means that this patient will react also to cakes which are made with egg. If they are, he will react to all types of egg products. If he is allergic to any of the other, ovalbumin, conalbumin, lysozyme, you will see that this patient, it's all heat-labeled proteins, so he will be able here to avoid raw eggs, maybe fried eggs, soft-boiled eggs, but otherwise he can eat it. And what we also see is that those patients, they lose their egg allergy quite quickly. So it's interesting to test those children after 6 months or after 1 year to really see if their egg levels are going down, because most of the time they do, where the patients which are allergic to ovomucoid, they have the tendency of keeping their egg allergy for longer time. And you see exactly the same with milk, where in this case you have the casein, which is the heat-stable protein. So if the patient is allergic to BOS-D8 to the casein, it means that he cannot eat any products, milk products. If he is allergic to any of the other components of milk, it means that he only has to avoid products where there is raw milk present. All the rest will work. We also see that it's the same thing as we see with egg, is that those patients which are allergic to the or react to the heat label proteins lose quicker their milk allergy than the ones who are reacting to casein. Although also the ones reacting to casein over time lose their allergy. One thing to be marked here is if you are allergic to BOS-D6, which is the bovine serum albumin, you also should look whether this patient could also have a reaction to meat, because it's one of the major components in beef. Hazelnut, and I think you can do exactly the same for peanut. I didn't include it here, but you could do the same for peanut, is that hazelnut, you have CoRA1, PR10 protein, heat labile, only oral allergy syndromes you will see for those patients which are CoRA1 positive. CoRA8, lipotransfer protein, risk of systemic reaction. CoRA9 and CoRA14, two storage proteins, heat stable. So in this case, we have 3 proteins in the hazelnut which are heat stable and which give you chance of systemic reaction. And if you would do it for the arachids, you will see the same thing for peanut. There you would have ARA-H1, 2, and 3, which are key important ones. ARA-H8, which is not very important, and ARA-H9, which is lipotransfer protein. Monret-Vautrin, in a study in France, showed that all the patients that had anaphylactic reactions to the peanut were all ARA-H2 positive. So it's really important. You have about 1 to 2 in 10 patients which are positive in skin prick testing or in ImmunoCAP to peanut who have a risk of a severe reaction. It's really important to figure those people out and say, your child has a real risk because it's ARA-H2 positive, so please be very careful with peanut compared to the other ones where you can say, probably you might have some small symptoms regarding to peanut, but it will never be a systemic reaction. I think it's, for the patients and for the parents, it's often very important to have this type of information. So that is the way the University of Antwerp presents it. It's to say, CoRA1, you can eat Nutella, CoRA8, CoRA9, you have to avoid it. I mean, the message can be pretty simple to the patient. I mean, it's not always that complicated. Go to one case. Should certain foods be avoided? Here we have a child, age 3. The child was diagnosed with egg allergy at 2 years of age. It had eczema, and the result, when the egg was removed, the eczema got better. And when tested 6 months ago, the level of ImmunoCAP testing for egg was 7 kilounits. And normally at 3 years of age in Sweden, they go to daycare. And now the question is, what is the risk of this patient going to daycare? Is it really a risk or not? So then you do the components, and you see that the egg white is at 3.2, and you see that the ovomucoid is below 0.1. So you can say that this child First of all, you had a substantial decrease in 6 months. You went from 7 kilo units to 3 kilo units. So probably he's losing his egg sensitization very quickly. And he's not allergic to ovomucoid. So at least everything which is not raw eggs he should tolerate. And that's just the simple practical point of view for the parents who are sending their children to school. Now, a few words about the ISAC for specific IgE. It's another type of approach. We have a microarray. On this microarray, we have put 112 components. I think that it's a highly advanced tool for revealing profiles of specific IgE. It's based on a multiplex technology. And we only use proteins in there. Multiplexing does not work when you use crude extracts. You really need to use specific proteins. The advantage of it is that it works with a very small amount of blood. You only need 30 microliters in this microarray to get 212 results. And you get, of course, a lot of information. And that's the way it looks like. The results, it's all colored dots, and the color gives the color intensity give you the amount. The total 112 components come from 51 different allergen sources, and every component is plotted in triplicate, so every result is done in triplicate to make sure that it's reliable. And you see where they come from. So they come practically from everything. I think it's not good for occupational allergy because those are not covered by this at all. If it's not occupational allergy, you have latex, you have paradise, you have venoms, cockroaches, mites, molds, animals like cat, dog, horse, cow, weeds, trees, grasses, fruits, legumes, nuts, egg, milk, fish and shrimps. So I think it covers quite a wide panel of allergens. And where would we use it? We would use it in multi-sensitized patients and complex patients. I would not use it for follow-up of most of the patients. I would use it in complex patients where you have difficulties or where they are multi-sensitized patients, for example, which have asthma and atopic dermatitis, which are often difficult to see whether this is a food allergen or this is an inhalant allergen or is it both. And I think that's the cases where you can use this type of symptoms. And it gives added results. This is from a group in Madrid, which said that by doing this, at that time called CRD, component resolved diagnostics, now we call it molecular allergology, but it's the same, that in 30% of the patients using the microarray, they had additional information that they did not expect. And when we look at a study from Wales, you can see that you have the same type of results. Those in 50% of the patients with idiopathic anaphylaxis, there were results that were not suspected. And I also would like to show here at the bottom that also the negative results are quite important. They had 8 negative scores that they didn't expect either, where they thought the patient would react to this or this or this, but the patient with this didn't react to anything. So also the negative results you get out of the ISAC give you an indication whether the patient is likely to react on it or not. And I think you have a similar result out of this Barcelona study, where you could see that they could detect 60% of cross-reactivity, which might not be so important, but 29% of co-sensitization. That means allergens, primary sensitizers that they didn't see if they wouldn't have done it. This is all done in multi-sensitized patients. So let's take food allergic patients. This Johannes, which is 5 years old from North Europe, and he has an egg at 21 kilo unit. He has milk at 2.9 at the age of 2, peanut at 2.2, hazelnut at 7.5. Skin prick test positive, ImmunoCAP positive. The correlation between the two tests is pretty good. Allergy to egg, the doctor diagnosed allergy to egg, milk, peanut, and hazelnut. Avoidance of egg, milk, peanut, and hazelnut. Asthma medication for short periods. Ointment for eczema, including topical steroids. And I think the list of avoidance, of course, if you have to avoid egg and milk, and it's present in so many products, it becomes an enormous list of things to avoid. Now, when we revisit this patient at the age of 5, and this is the way the ImmunoCAP results are presented, you see that you have a GALD2 positive, but not GALD1, so you don't have ovomucoid, so you only have ovalbumin positive. And also, his level is at 2.2 compared to 21 to egg before, so it has decreased tenfold. The chance that this child is going to react to egg is very low, so probably we can at least reintroduce egg and see if it gives any problem. When we look at peanut, however, it's a RH2 protein which is positive. That's a storage protein at 6.4. So this patient still has to avoid peanut. It's a very risky patient for having reaction to peanut. And the same is for RH3 for peanut, another storage protein which is positive. Then we have the birch which is positive, the BETV1 which is positive, the PA10 protein. It's also a primary sensitizer, so we can imagine that this patient during the birch pollen season in Sweden will have problems with rhinitis and could have problems with asthma. So we will give antihistamines during the pollen season and asthma medication when needed. But when we look at the other ones, is that the birch is positive, but the other PA10 proteins are positive also, and that means alder, hazelnut, and they will not influence his allergic status. So he can easily tolerate all products based on hazelnut. So now you have this patient with a much less restrictive, the milk is gone, the egg is not important, and you really get a patient where you say, okay, what do we have now at the age of 5? We have two things to look for. We have to look for peanut allergy, and we have to look for the inhalant PA10 problem that he has with rhinitis and asthma.
We have only 3 minutes, please. 3 minutes.
Yeah. That will be roughly the last slide. So as it is a lot of proteins, we have also made a software to give an explanation on the proteins, and I just want to show how this explanation is working. When you have the results, how they are presented. First of all, we present here the specific components. Like we said, it's the specific components, and here you have a patient which is FLIP-P1 positive and FLIP-P5 positive. So this is a patient which is generally primary sensitized to grasses. He's a grass allergic patient. And then you have another in latex. It's HEF-B5 and HEF-B6. Those are two primary sensitizers in latex. So this patient has also the risk of having a reaction to latex. I think that is what we have to look at. As he does cross-react with some of the fruits, it's also interesting to ask the patient whether he has a problem with bananas or melons when he eats them. And primary sensitized to cat, because you see the FLD1 is positive and you have, it's a primary sensitizer for cat. Then we have the profilins, which are clinically unimportant but would give you positive results. All those tests of profilins probably are not very meaningful from an allergic point of view. So we don't have to be bothered about, for example, olive tree, because it's only the profilin which is positive. And so we don't have to look. We don't have to be looking at birch, because it's only the profilin for birch which is positive. It's not the BETV1 which is positive. And then we have the serum albumin. And the serum albumin is positive for milk, cat, dog, and horse. The result of this is that the patient could react to these serum albumins, but it will be mild symptoms in general. So that's a little bit the way you can work with it. I think I will end here the presentation. If there are any questions, you can put the questions in French also. I'm from Belgium, so je parle le français aussi. Donc, si vous voulez poser les questions en français ou en anglais, avec grand plaisir.
Merci, Dr. Delobel. Si vous voulez 2 questions rapides. Parce que nous avons terminé dans le temps. Pas de questions? Ok, c'est bien. Merci. Les enfants.